Hi, everyone. This is Kathy Bush, and Alex Luton and I, our Director of Education, would like to welcome you to the DandleLION Medical webinar titled Long-Term Developmental Consequences of Positioning After the NICU Stay. Our faculty presenter this morning is Chelli Westengaard. Chelli's been a pediatric occupational therapist for 22 years. She works with children with developmental challenges across the continuum and is currently the clinical director for a pediatric outpatient clinic, Treetop Therapy, that offers physical, occupational, and speech therapy services. She has worked with critically ill infants both as an occupational therapist and developmental care specialist in the CCU and NICU for 9 years. Chelli's been a member of the National Association of Neonatal Therapists, received her neonatal touch and massage certification, and the developmental care designation from NAN. Chelli has presented on numerous topics related to neuroprotective caregiving in the NICU, as well as developmental feeding at Grand Rounds. She helped to collect and present data that was selected at the State of the Art Nursing Conference and also the Advanced Practice Nursing Conferences from the Academy of Neonatal Nursing. Chelli does have a lot of videos in her presentation, which you are going to love. If they don't show well on your computer, you might want to come back to the recording once you get that in a day or two. It very likely could be a problem with the transmission on your end, but don't worry, you will be able to see them at the recording. So Chelli, thank you so much for being with us and welcome to you.
Thank you. Thank you so much for that nice introduction. I'm excited to share all of this information with everybody. So today we're going to talk again regarding the long-term developmental consequences of positioning after the NICU stay. Our objectives today, I'm going to move our video over here, is to identify at least 2 important musculoskeletal changes that occur in the last trimester of development that play a significant role in meeting developmental milestones. 2, we're going to, hope that you're able to describe at least 3 intentional positional strategies to support musculoskeletal development. And last, list at 5 or more developmental implications that occur as a result of poor positioning in the NICU. For disclosures, I have no conflict of interests to disclose today. And I'm going to go ahead and get started. Neonatal therapists, nurses, and professionals have a unique opportunity to observe early movement patterns and posture in neonates and newborns. They are able to work together to promote motor development and prevent or minimize musculoskeletal deformities. An infant's neuromotor development benefits from a 40-week gestation. A healthy, full-term infant has musculoskeletal and neuronal pathway advantages compared with infants born prematurely. The video you have been watching is a 9-month-old baby in 4 hours of play condensed down to 2 minutes. You can see how busy a little one is moving, rolling, reaching, kicking, grasping, crawling, babbling, and walking. Our goal in the NICU is to promote and protect our little ones so that they can develop and move just like this one. I'm going to turn the sound on here and enjoy all that movement. We're first going to discuss the musculoskeletal maturation to include the skeleton, muscles, and joints. We will then discuss the function of these systems as it relates to tone, movement, and development. Beginning around the 3rd week of gestation, the spine and ribs are first to develop. Defects in the vertebral arch, such as spina bifida, result from disrupted skeletal development in the 4th week of life. At this time, arm and leg buds begin to appear. During the 4th and 5th week, limb anomalies can occur. At 16 weeks, the baby starts moving their limbs in a coordinated way, although movement may not be felt until 18 weeks or later. By the 3rd trimester, the skeletal system is fully developed. Some research suggests fetal movement helps strengthen their bones. Joint structures develop in the 6th through the 8th week of gestation. This is when fibrous and cartilaginous connective tissue or synovial membranes develop between bones at articulation points. Development and alignment of limbs and joints can be altered by intrauterine conditions. The presence of ligament laxity and connective tissue elasticity predisposes preterm infants to developing joint effusion or subluxation during intense range of motion activities. Respiratory equipment and multiple lines used in the NICU restrict variability in positioning the fragile neonates. These infants experience prolonged pressure and compression of limbs and joints and minimal refinement of joint receptors. Within the constraints of neonatal equipment, infants can experience varying forces and pressure through joints and muscles that promote joint and proprioceptive development for coordinated movements. By 20 weeks gestation, muscle tissue differentiates into slow type 1 and fast type 2 twitch fibers. Type 1 muscle fibers continue to develop while preterm infants are in the NICU, but remain at a decreased ratio to the type 2 fibers. Preterm infants are predisposed to muscle fatigue, particularly in the respiratory muscles. This is most likely related to the lower ratio of high oxidative type 2 fibers in preterm neonates. Low tone and difficulty sustaining postures may also be related in part to this muscle fiber disparity in preterm infants when comparing to term infants. At term, type 1 and type 2 muscle fibers are expected to be equal in number and to resemble the pattern in adult muscles. The movement experience of a term infant differs from that of a preterm infant. The infant born at term has moved within a well-contained and stable environment, receiving a variety of proprioceptive and sensory input under ideal physiologic conditions. Term infants are equipped with effective muscle power, tone, and movement to respond in dynamic patterns within the extrauterine environment. When a preterm birth occurs, muscle tone, posture, and movement continue to develop, but the infant now must adapt to the influences of gravity, tactile, and proprioceptive stimuli from prolonged lying in a bed or mattress before the musculoskeletal system is ready to deal with the forces and weight bearing. A fetus in the womb has dynamic circumferential boundaries at all times. Active movements occur within consistent and predictable boundaries. Resting posture typically is flexed and contained with midline orientation of the head and extremities. Limited intrauterine space in a full-term pregnancy creates a postural bias toward physiologic flexion, contributes to normal soft tissue contractures, and temporarily limits range of motion in knees, hips, elbows, and shoulders. Physiologic flexion provides full-term newborns a beneficial degree of early motor control in the flexed midline ranges. Gravity and spontaneous movement gradually reduce physiologic flexion over several weeks. The infant's motor control then will appear decreased in newborn. Physiologic flexion is replaced by the development of balanced anti-gravity flexion and extension. Factors that encourage a flexed posture after birth and promote early motor development in healthy, full-term newborns usually are not present for infants born prematurely. Extremely preterm infants have incomplete development of muscle tissue, joint structures, and bone density. Muscle tone is typically hypotonic. The infants may have some extremity flexion, but their limbs are typically abducted, externally rotated, and lying flat on the surface in an M or W position. Because physiologic flexion has not yet developed, preterm infants lack the internal or musculoskeletal motor control of full-term infants. Additional issues such as illness, energy depletion, gravity, and weight or compression of medical lines and tubes compound the problem. Extremely preterm infants at full-term age equivalency usually appear motorically different than a newborn full-term infant. Their active extension is stronger, asymmetry is common, and spontaneous movements are large and poorly controlled. The principle of activity-dependent development refers to influence of repetition, the formation of neural connections and pathways. In this use it or lose it framework, neural connections that frequently are activated, strengthen, and become dominant. Potential neural pathways that rarely are used are weakened or disappear. In other words, as we've heard before, neurons that fire together wire together, and neurons that don't won't. This neonate we're going to watch is at 32 weeks gestation. Muscle tone is viewed as the tension in a muscle at rest. It is the muscle's response to an outside force, such as a stretch or change in direction. This tone enables our bodies to quickly respond to a stretch. Passive tone is measured by the amount of resistance offered in response to passive movement. Passive flexor tone in term infants is related to the movement constraint of uterine wall resistance during fetal growth in the last trimester. At term, equivalent age preterm infants do not reach the same level of flexion as infants born at term gestation. The advantage of strong physiologic flexor tone at birth enhances head control, midline posture, and suck-swallow proficiency. Tone involves sustained muscle contraction necessary for maintaining posture against gravity and is fluid, adaptive, and constantly changing in response to movement. Decreased tone in preterm infants may be partly influenced by the decreased proportion of type 1 compared to type 2 fibers in the skeletal muscles. Development of infants' tone and posture has been reviewed and studied throughout the years. The consensus is that preterm infants are hypotonic and the subsequent development of flexor tone follow a caudal to cephalo progression. Dubowitz and Dubowitz reported a longitudinal study of the progression of flexor tone in 57 low-risk preterm infants at 28 to 35 weeks post-menstrual age. They measured passive extremity tone by traction, recoil, and popliteal angles. Earlier assumptions were confirmed on the chronology of passive and active tone, including flexor tone progression in a caudal to cephalo direction. Allen and Caput documented the beginning of leg flexion at 29 to 32 weeks and arm flexion at 35 to 37 weeks. Because of this maturation-related hypotonia, caregivers play an important role in creating postural support for extremity flexion in both legs and arms. Groot and colleagues concluded that preterm infants have low muscle tone measured by resistance to traction or passive movement. Differences in muscle power between preterm and term infants were attributed to differences in weight and muscle mass. They noted that some preterm infants appeared to develop exaggerated active muscle power expressed by hyperextension of the trunk. Prolonged positioning of preterm infants in supine was hypothesized to be the stimulus for overactivation of neck, trunk, and hip muscles in contact with the supporting surface, causing exaggerated extensor power or arching. Overactivation of extensor muscles was considered to be out of synchrony with the level of tone maturation in other muscle groups, creating more disorganization from a mismatch of intensity of timing between extensor and flexor groups. Ferrari and his cohorts found that stress induced by abrupt physiologic changes and conditions results in disorganized movement and posture. No position is totally free of its effects on the infant, and every position the infant experiences influences multiple systems. Intentional strategies that we as caregivers can use to promote optimal development include optimizing alignment. The goal is to focus on a neutral neck and trunk, flexed midline extremity posture, and neutral foot alignment. Next, we want to support posture and movement. Provide containment and boundaries or a nest of rolls, swaddling blankets, and other positioning aids. We want to try and avoid creating an environment that does not allow movement. The boundaries should be tall enough that if the infant kicks, there should be a rebound or recoil effect, and the infant should return back to that flexed position. We do not want the lower extremities to remain in an extended or be stuck over the top of any type of boundary wall or remained in an extended position. Next, we want to modify positioning and handling to promote state regulation and quiet, calm behavioral states. Our goal should be to enhance a short duration of interaction and encourage sleep states that promote growth and development. We do not want to rush through cares. Keep your movements calm and slow, and try to maintain a quiet state throughout procedures. Offer positions that allow controlled, limited exposure to proprioceptive, tactile, visual, or auditory stimuli. We want to monitor closely for signs of behavioral stress from potential overstimulation. And lastly, when caring for the infant, do everything with intention. Complete each set of cares, each change in position, each diaper change, every interaction as an opportunity for nurturing, connecting, and fostering optimal growth and development of the infant. Ferrari and colleagues investigated the effects of nesting on posture and spontaneous movement in 10 healthy infants observed at 30 to 40 weeks post-menstrual age. A significant difference was found on the quality of spontaneous motor behavior in the nested infants compared to infants in a non-nested or contained position. They concluded that nesting supports flexion of the arms and legs with adduction of the shoulders and midline movements. Nesting was found to reduce the frequency of abrupt extremity movements, which have a disorganizing effect on the posture. By the time the preterm infant reaches full term, they are expected to demonstrate the following postures and motor competencies to be commensurate with age-like peers. Maintain a semi-flexed extremity posture, both in supine and prone positions. Move their head from side to side, both in supine and prone. Lift their head in prone and hold this position momentarily in supported sitting. Maintain head in line with their trunk during pull to sit. Bring hands periodically toward midline. Sustain a rhythmic suck, swallow, and breathe sequence. And lastly, demonstrate movements that support behavioral state regulation, such as bringing their hands to mouth. Although preterm infants at term may not demonstrate the same level of active postural tone as a term infant at 40 weeks gestational age, neonatal caregivers can create a supportive environment to help them reach similar stability and midline movement. The structural function and elements that we have just discussed are the foundation for coordinated motor behavior and musculoskeletal development. The following is a video from pathways.org. Watch two babies in different positions to compare their motor movements. The side-by-side clips allow you to see the differences in movements between the two infants. One baby is developing typically and the other atypically. Notice the differences in motor movements, tone, and behaviors. Neonatal caregivers can use the rapid growth and joint laxity found in the neonate to promote musculoskeletal alignment and motor organization while the infant remains in the NICU. The plasticity and growth of the musculoskeletal system can result in both positive and/or negative effects. The rapid growth combined with inattention to body alignment can contribute to positional deformities in the skull and extremities in a very short amount of time. Shaping of the musculoskeletal system occurs during each body position experienced by infants in the NICU. Supporting skeletal integrity, the neonatal infant is challenging with an environment of multiple equipment obstacles and handling limitations by fluctuating physiologic stability. Skull deformity and extremity malalignment are not uncommon and result from the combination of maturation-related hypotonia in neonatal care procedures, such as prolonged ventilation or extended angled positioning, in which symmetric midline postures are difficult to maintain. Please feel free to visit the Pathway website for additional information on development through the stages. I'm going to turn the audio on for just a little bit so that we can hear some of the narration of what we are seeing.
Baby on the left's upper body is free to lift his head and upper trunk off the surface. Note that the changes in leg position on the atypically developing baby allow him to begin developing head and trunk control. Hip position. Watch baby on the left moving out of flexed into flexed and adducted position, while baby on the right remains in flexed in abducted posture. Movement. Notice the baby on the left is doing little weight shifts and is able to counteract with his abdominals to balance, while increasing shoulder girdle strength. Baby on the right strategy is to extend and push up on his legs. It doesn't assist him in lifting his head and pushing up on his arms. Position 4, pull to sit.
Cephalocaudal development literally means from head to tail. Babies develop motor strength and muscle control starting at the top, cephalo, toward the bottom, cauda. This is why tummy time, which strengthens the head, neck, and upper trunk muscles, is so important. Infants will first develop head and neck control, then upper body strength in their arms, shoulders, and upper torso, then lower abdominal strength, and finally, the balance and strength needed for sitting, crawling, and walking. We also develop musculoskeletal control proximal to distal. This means from near to far, with near referring to the center of the infant's body. In other words, development starts at the center, with increasing control gradually spreading from the center outward further and further. As an example, first the infant will work to control his arm movements, maybe to reach or fling his arm out in the correct direction to hit a dangling toy. Then his whole hand, He'll grab something with a large, gross grasp pattern. Then finally, his fingers, the ability to use a pincer grasp to pick up a bit of cereal or one finger to point or poke at a toy. Mobility comes from stability. Both principles of development, cephalocaudal and proximal distal, exist and work together simultaneously. Though timing may vary from baby to baby, the order that the developmental achievements occur will remain similar. Babies must achieve head control before they are able to work on sitting or walking. A baby needs to be able to control his arm movements before he can learn to pick up a small bead. There are two areas of development that therapists focus on. The first is gross motor development. This refers to the bigger body muscle groups and movements. Some examples of gross motor milestones are head control, sitting, crawling, rolling, standing, walking, and then running. Fine motor development refers to the coordination of the smaller muscle groups, such as intentionally bringing hands to mouth, passing a toy from hand to hand, or picking up a small bite of food. This is a gross motor milestone chart. As motor skills develop, there are certain developmental milestones that young children should achieve. For each milestone, there is an average age as well as a range of ages in which the milestone should be achieved. An example of a developmental milestone is a baby holding up its head. Babies, on average, are able to hold up their head at 6 weeks old, and 90% of the babies achieve this between 3 weeks of age and 4 months of age. If a baby isn't holding their head up by 4 months old, he is showing a delay. Another example is, on average, most babies sit alone at 7 months old. Sitting involves both coordination and muscle strength, and 90% of babies achieve this milestone between 5 and 9 months old. Again, if the baby was not sitting by 9 months old, that would be a red flag, and further screening may be needed. In clinical terms, there are a few absolute indicators, often referred to as a red flag, that identify the behavioral or developmental milestones, suggesting the need for further evaluation. For a parent or caregiver, these red flags should serve as a catalyst, prompting developmental screening to ensure that the child is on the right developmental path. In the next few slides, we are going to take a look at some of the developmental implications that can occur if intentional positioning and care is not at the forefront in the NICU at all times. Primary sites for infant malalignment during the NICU stay includes shoulders, hips, and feet. W arm posture includes scapular adduction, shoulder elevation, and external rotation. This can accompany an excessive neck and trunk extension posture in preterm infants. This abnormal upper extremity position can interfere with reaching shoulder stability in prone, rolling, and crawling. Shoulder retraction and ankle eversion were reported in NICU graduates from ages 3 to 8 years of age, linked to prolonged W and M extremity postures during the NICU stay. These posture deformities disrupt the continuity of musculoskeletal development, and that began in utero and was shaped in the NICU environment. We can help minimize these deformities by using the intentional strategies previously discussed. We're next going to review several videos demonstrating how poor positioning can impact development. Positioning and neuroprotective initiatives play a large role in the development of an infant in the NICU. It is not the sole reason that a child may develop delays. There are multiple reasons for this. It is our role as caregivers to help prevent and protect when we can. The following are some terms that will be used to describe the movements and delays in several of the upcoming videos. The first is scapular retraction. This refers to moving the shoulder blades toward the spine. Next is elevation of shoulder girdle. This is a movement where the scapula moves in a superior or upward direction. Shoulder external or internal rotation is a movement when your arm is out to your side and internally rotating or turning your arm inwards, or external rotation, turning your arm outward. Hip abduction is the movement of the leg away from the midline of the body. Torticollis is a condition in which an infant holds their head tilted to one side and has difficulty turning their head to the opposite side. Ankle eversion is the movement of the sole of the foot away from midline, and inversion is the movement of the sole towards midline. When measuring a baby's development or determining what is typical for that baby's age, we want to determine the corrected age. By looking at the difference between the due date and the actual delivery date, you can adjust for the baby's age to account for prematurity. You would then compare the baby's corrected age to other children at that age, not their chronological age. During the first 2 years, using the baby's corrected age will give you a better idea when he or she should reach common developmental goals. After 2 years of age, the baby should be caught up developmentally with their peers, and corrected age is no longer considered. Plagiocephaly, or skull flattening, continues to evolve after the NICU discharge with overuse of infant seats and limited prone play activities. If strong head turn preference remains and asymmetric occipital flattening occurs, a secondary torticollis, or lateral head tilt, from sternocleidomastoid muscle tightening is likely to emerge. Collette and cohort found school-age children with moderate to severe positional plagiocephaly scored lower than controls on cognitive and academic measures. Associations were negligible among children with mild plagiocephaly. The findings do not necessarily imply that these associations are causal. Rather, plagiocephaly may serve as a marker of developmental risk. Their findings suggest a role for assessing positional plagiocephaly severity in clinical practice, such as providing developmental assessment and intervention for infants with more severe deformation and guidance for those with mild deformation. Muscle tightening of neck extensors, known as torticollis, can affect both gross motor and fine motor skills in the infant's ability to rotate the scapula, interfering in reaching and grasping, propping and prone, impacting head control, rolling, and crawling. Also, if the infant is always looking in one direction, it can impact their function and sensory awareness on the alternate side, thereby impacting their developmental progression of milestones. Atypical upper extremity tone, posture, and movement can include shoulder external rotation, scapular retraction, increased neck tone, and arching, resulting in the inability to prop and prone, poor head control, inefficient movement, difficulty rolling and crawling, or bringing hands to mouth. I'd like you to meet Ellis. She is a corrected age 3.5-month-old little girl. Ellis is beginning to use lateral head righting when she brings her arms across her body in horizontal abduction, but she is requiring assistance from Sam, her physical therapist, to provide downward pressure on her hips to complete the roll. She is unable to bring her arms under her body to assist with prone propping due to her tight back extensors and tight hip flexion. In the second video, Ellis is showing minimal cervical extension due to poor upper extremity strength and stability, strong scapular retraction, and external rotation. Notice when Sam provides support at the upper trunk and shoulder girdle, she is able to lift her head to 45 degrees. Next, I'd like you to meet Nora. She is a 15-week, corrected age 13-week-old little girl. In the first video, Nora is showing the beginning signs of active shoulder engagement with pull to sit. She is starting to attempt a chin tuck, however, needs assistance with a gravity decreased position or semi-reclined in the therapist's knees. Notice how she utilizes her right tight sternocleidomastoid muscle to assist with movement, as seen by the increase in right head tilt. Pause here, and I'm going to start this over because I want you to really watch for what we had talked about, and I'm going to turn the sound on because I'd like you to hear her giggles. And this one I'm going to bring back. In the second video, Nora is working in a vertical seated position. The goal with this activity is to work in a gravity-dependent position with the focus on head control and midline orientation. She is beginning to demonstrate head riding reactions when tilted more to the left due to the right side strength overpowering. This is Nash. He is 7 months old. In this first video, you can see how his tight back and shoulder muscles are interfering in his ability to weight shift over either arm and laterally flex his head to move the opposing arm forward to pivot. His tight trunk, causing the C posture, results in tight hip musculature and causes an inability to extend his lower extremities in prone. In the second video, Nash has his arms extended and shoulders adducted. He is unable to horizontally abduct his arm for rolling. His tight back and hip muscles, as well as overriding scapular retraction, are interfering in his ability to roll. He struggles to break out of this position to abduct across his arms and legs. I'm going to play it again so you can kind of keep watching, and initiate the rolling sequence. Again, you can see the C extension position interfering in developmental progression of milestones. So this is definitely what we see when that M position or W position in the NICU overrode, and that tightening through the back causes a lot of these developmental implications. Meet Turner. He is a 13-month-old corrected little boy. Due to the tight shoulder internal rotation and scapular retraction, Turner is unable to creep forward with neutral shoulder alignment. He also has tight biceps, secondary to limited full upper extremity range of motion, and is limited in reaching, supination, and pulling to stand. Turner does not fully flex his lower extremities throughout the entire range and uses his trunk extensor musculature to progress forward versus using his lower extremities to crawl. I'm going to play that one more time because I really want you to see where he's using his back muscles versus, flexing those hips to crawl. And also his really interned arms, internally rotated. Here. So I would like you to meet Eleanor. She is a corrected age 14-month-old little girl. In this video, she is maintaining a very wide base of support. She holds her lower extremities in external rotation due to hip tightness and decreased weight bearing over the strength in her legs. You also can see that she is positioning her feet in ankle eversion despite attempts to place in neutral. Next, I'd like you to meet Aaron. He is 27 months old. These two videos are examples of low tone affecting his reach, fine motor control, and grasp. Due to the low tone throughout his trunk and upper extremities, Aaron struggles to reach and grasp for objects in a controlled, precise manner. As we talked earlier, mobility comes from stability. This is a great example of how a weak core and shoulder girdle can have a significant impact on his developmental abilities to reach, grasp, manipulate, and isolate his fingers. He is not yet able to use a pincer grasp, isolate his finger, or release without a surface. In these videos of Aaron, you can see how difficult it is to control his body. Notice how he keeps his legs as wide and externally rotated for increased support. This is due to lack of core strength and low tone. He tries to use his back extensor muscles to maintain his weight with a posterior weight shift versus anterior. He has shortening of his back extensors, which interfere with anteriorly rotating his pelvis. He is using his step reflex versus a controlled pull to stand. When walking, he requires maximum support for weight bearing. Notice he has ankle orthoses to help provide additional stability for weight bearing. When attempting to walk, he again is using his step reflex versus intentional and controlled step pattern. I'd like you to meet Tegan. Tegan is a vibrant, outgoing, young 11-year-old boy. He was born on January 3rd, 2010 at 26 weeks and 5 days gestation. He spent 106 days in the NICU. Tegan was vented for 1 month, BiPAP for 2 weeks, and then transitioned from high flow to requiring oxygen at home. Tegan met all of his developmental milestones. However, they were all on his own timeline. His mother, Monica, reports that they were typically around 6 months behind the average kiddo his age. She states he was slow to crawl, he struggled weight bearing over his arms and knees, and was unable to hold his knees together to crawl. He preferred to W-sit due to weak core muscles and tight hip abductors. He preferred to roll to get what he needed. He started to walk at 18 months corrected. Mother said he looked like a drunk sailor with a very wide base of support and poor balance and body awareness. Tegan did receive occupational and physical therapy to help him and his family reach his milestones. Monica reports that Tegan now has a learning disability, dyslexia, and several sensory issues, such as he prefers not to be touched, very cautious with movement, and a bit anxious to try new things. Tegan is going to be starting middle school. He enjoys baseball, video games, swimming, dancing, and hanging out with his friends. I'm excited to introduce you to Turner. Turner is a 16-month-old corrected to 13-month, handsome, blue-eyed boy who is an identical twin. Turner was born at 27 weeks, 5 days gestation and weighed 3 pounds, 2 ounces. He spent his first 85 days in the NICU. Turner was intubated for only 1 day and transitioned to CPAP. He had a difficult time transitioning to nasal cannula and then room air. During his stay, he was diagnosed with a UTI, E. coli, and struggled with reflux and milk intolerance. Turner's mom, Rachel, states that his initial head scan was normal. However, after 7 weeks in the NICU, Turner had an apneic period where his heart rate dropped to 30 beats per minute and O2 sats dropped to 13%. The repeat head scan then showed mild PVL or periventricular leukomalacia. Rachel reports Turner was the first brother to roll and bear weight over his arms. Turner was able to roll at 5 to 6 months and sit independently at 9 months. He has good fine motor skills and his reaching continues to improve. Rachel states that when they attended Turner's 12-month annual checkup, the doctor was concerned with his stiff legs, weight bearing on his toes, ongoing startle reflex, and his tight hips. In February of this year, his parents noted that his twin had been moving more and that Turner was not progressing. Let's start this video. You can see in both of these videos, Turner is using his increased tone, scapular retraction, and tight shoulder external musculature to roll. Put him back up. You can see he's still tight, kind of right back to the same position. These days, Turner enjoys to eat. He loves his food and snacks. He loves looking at books and throwing them off the bookshelf. His favorite thing to do outside is to play in his playhouse. His mom states that he isn't 100% sure about the pool yet, but he has lots of time and opportunity to come. Shut that off for a second. A quick note about Turner from his physical therapist, Samantha Erickson. When I first evaluated Turner, he was not army crawling, creeping, or pulling to stand. He was unable to maintain weight through extended legs and maintain physiologic flexion in all extremities. Turner has full body stiffness and has increased tone globally. During all upper extremity weight-bearing tasks, Turner prefers to keep his arms internally rotated, is unable to extend them straight, and is unable to supinate or pronate forearms due to increased tightness and decreased upper extremity strength. During lower extremity weight-bearing tasks, Turner maintains knee flexion and utilizes a crouch gait to ambulate with handhold assistance due to increased tone and muscle weakness. Turner is now crawling independently, pulling to stand, cruising, walking with handhold assistance, and standing independently for 1 to 2 minutes. We are currently working on floor to stand transfers and independent ambulation. He is very opinionated, and when he does not want to stand, walk, or creep up the stairs, he lets everyone in the clinic know it. The premature neonate is both dependent on and vulnerable to the intensive care environment to support both physiologic and neuromotor development. The NICU environment, specifically neuroprotective positioning, plays a major contributing factor in the developmental progression and milestone achievement. By modifying the neonatal intensive care environment to provide a more developmentally supportive setting, we can better help meet the infant's neuromotor needs while supporting growth and development. I want to thank you all so much for your time today. I hope that you leave with the knowledge of the important musculoskeletal changes that occur and that play such a significant role in meeting developmental milestones, that you're able to describe intentional positional strategies to support musculoskeletal development, and have a better understanding of the developmental implications that occur as a result of unintentional positioning in the NICU. Thank you again.
Oh, Chelli, that was so awesome. The video that you had really made such a difference. It made, everything so clear, and to be able to see that and listen to you as you were going through them, that was wonderful. Can't thank you enough for this amazing presentation. Let's open it up to Q&A. Kathy Randall and Alex Luton are both going to help us with that.
Yep.
Anyone that has a question, please put it down in the Q&A down at the very bottom of your screen, and Chelli will answer as she can. Now we'll put them in the Q&A, not the chat. It's really too hard to go back and forth. So Kathy or Alex, are you there to start reading the questions?
Sure. So Susan has a question that says, I understand the benefits of the nest for preterm infants. How long does this positional strategy benefit babies, and when can this support be faded away?
I would say, and you guys might have a better idea on this. I'll take any assistance from you guys. I'm more on the back end of things anymore. But I would say at least till 37 weeks. You want to definitely give them that opportunity once they hit more of a term age, that they're getting the opportunities to really kick out and explore, and not be quite so contained into that physiologic flexion position.
Okay. Awesome. Thank you. And the next question comes from Jessica. She says, do you have any resources about the wrapping and positioning techniques that are recommended to maintain flexion without restricting?
I would say there are lots of positioning aids out there that have wonderful materials that, one, if you don't have the actual aid where you can wrap them and bring them, they are able to kick out, and that material will bring them right back. Definitely having that in kind of the forefront of your brain where you want to try and create that using blankets, rolls. Like I said, there's different, DandleLION has wonderful products out there that help promote that physiologic flexion and that full containment.
Okay, great. Thank you. And then our next question comes from Dorothy, who's an occupational therapist. She says, for hospitalized infants, at what age do you move to fairly consistent back to sleep as compared with allowing extended prone time? We run into issues at our hospital with nursing and medicine wanting them mainly supine and therapy wanting more prone time. Thank you.
I completely understand that question. We've run into that ourselves in the hospital I was at. The goal is definitely, back to sleep. You want to also promote that for the families there, because you want them to go home with that same back to sleep mentality for safety. I would say, just as if you were at home with that infant, giving them opportunities through the day, observed in prone. I know that's easier said than done in the hospital setting, but, being able to give them some time in prone, because there's so much developmental milestones that are based off that position. One of the things that I know we always told families at discharge was a goal of at least 10 minutes a day, which does not seem like much, but some babies don't love that position. And so even if it's, a couple minutes here or there, if the goal is 10 minutes, they're going to get used to it and start gaining more and more tolerance to it, and building the strength through their upper shoulder girdles, trunk, head.
Okay, great. Thank you for that. And then I had a question about the role of infant massage. So when I hear you talking about activated extensor tone or being hypertonic globally, does infant massage during the NICU stay have any impact on that kind of overactive tone situation? Does it provide any sort of relief from that? It may not. I'm genuinely curious.
I don't know if I feel bad not knowing this exactly, but I don't know if there's a study out there that says it, but I have been trained in it and I saw a huge difference in it. Just being able to provide that calming touch and relax, and then giving parents that opportunity as well. You just see babies kind of relax and melt into the mattresses. So it definitely gave them, if they were kind of a high-strung baby and startled easier and some of those reflexes weren't integrated, it was a great way to kind of provide that input to them to relax and bring more of that flexion piece in.
Great. Okay, any other questions from the group?
Another one about in the chat area from Jessica. Do you have any resources about wrapping and positioning techniques? Did that already get answered?
We did that one.
Thanks,
Yeah, we did. And Anne has a question now that says, how often do you offer massage in the NICU?
I wish all the time. When I know we always offer it to the families, I kind of had a different, I would love to say several times a day with every baby, but that's just not realistic. My goal was always to teach the families and the nursing how to do it. And a lot of times, bath days, they'd always give me a call, and we do that right away with if they had a really fussy baby, I would get calls for that as well. I don't think you could probably do it too much, but I wish we could do it all the time, because I did see a huge benefit with the infants.
Great. Thank you so much. Susan has another great question that says, for medically challenged babies that cannot be easily repositioned due to decreased pressure on the back of the head, what products have you used to decrease pressure on the back of the head and reduce the worsening of plagiocephaly? So how do we support, kind of normalizing the head shape when they have to be on their back for an extended period?
They do have different gel pillows out there. There's all kinds of products that would kind of help take some of the pressure off. One of our goals was always to try and change that position as much as we could, especially every cares. I think our rule generally was every 3 hours, no same position for up to 9, after 9 hours, then you can repeat them. For some of those medically fragile, you just have to do the very best you can if you're limited. I know some, especially with respiratory, they breathe best in prone, and you just have to do the very best you can, giving them opportunities. So there's definitely situations that, as long as you feel like you're doing your very best to provide that, neuroprotective care, you're doing what you can.
Great, thank you so much. And Megan has another question. It says, how can you support an infant's position when doing kangaroo care?
Well, if they're up on the mom or dad's chest, definitely just bring, mom can hold them in that flex position. They're in prone already. So it's a wonderful position to already, give them those little tiny opportunities to weight shift and bring that head up. There's all kinds of wraps out there that kind of can help the parent hold that containment or flex midline position as well.
Okay, great. Thank you. And Anusha has a question. Anusha says, do you offer swaddled bathing now for preterm infants?
Yes, we do. When I'm in the outpatient world now, but when I was in the NICU, we definitely encouraged and trained and taught families and caregivers and all the nursing staff swaddled bathing. Mm-hmm.
And Dorothy has a follow-up question about infant massage. She says, do you recommend any infant massage, or specifically the certification for neonatal touch and massage? You are certified in that, right?
I am. So I guess I love that neonatal touch and massage. I'm not familiar with other ones, so I hate to say this is the one and only, but I really am happy with the neonatal touch and massage.
Good. That's a great recommendation from the front lines, you know. And what age typically can we start infant massage?
Once they're stable enough to tolerate touch and there aren't probably umbilical line, things that might get in the way, you can start. I think it's a great way to get families involved right away.
And it might look different for your very, very preterm infants than it would for an infant that's, been around chronologically for longer, right?
Exactly. Mm-hmm. It kind of be up to hospital policy.
Sure. Janice says, we have safe sleep guidelines that we must follow. Some of these babies are less than 37 weeks, so we cannot have them nested. Any ideas for developmental positioning for these patients?
I'm not quite sure I understand the question.
So if you have a baby who's has to, so safe sleep guidelines are implemented, let's say around 34, 35 weeks, for example, and the baby is still preterm, quite a bit preterm, but they can't have any sort of nesting because of hospital policy around safe sleep guidelines. This is a very common question. How else can we support those babies when we can't nest them in the same way we would, say, in an incubator?
Oh, goodness. So like if they've moved out to a cribette or a crib, that's kind of the policy. I would say really try and get an activity kind of schedule for them. So there's people, there's all kinds of volunteers or, CNAs going in and providing some of that containment, holding, so that you're getting them that opportunity as much as possible.
Mm-hmm. Absolutely. And it's hard, I think, sometimes because we think about, if you think about a baby who was born at 23 weeks and what their needs are when they're 35 or 36 weeks versus a baby who was born at 34 weeks and what their needs are at 35 or 36 weeks, when we try to apply, safe sleep policies that were originally written for 40-week healthy term babies at home, and we try to kind of blanket those across the NICU, I'm not sure enough has been considered as far as the developmental needs of those babies, that we're still the pregnancy, we feel like a 34-weeker is a huge baby, but that baby really still has 6 weeks of pregnancy left and is missing out on all that interuterine crowding, and all that really important flexion and proprioceptive input and all those things towards the end of the pregnancy. So it's hard for the providers at the bedside really to advocate for what's developmentally appropriate for the baby when the policies, globally seem to kind of contradict the message that these babies really still need a lot of positioning support. And the providers at the bedside are in a tough spot.
Yeah, they are.
So the next question is there a time when you start to promote more extension in the lower extremities in prone? I know we want to promote physiologic flexion a lot in the NICU. So when do we want to promote extension?
It should naturally occur if they are in prone. That kind of weight bearing through their hips is going to kind of naturally provide that extension. When that flexor tone overrides, that's kind of one of those, after so many months, that's when you kind of get those red flags we talked about, to maybe look into it a little more.
Okay. And do we need to use oil when doing infant massage?
Yeah, we used one of the lotions that was on unit because we had a hard time getting oils passed in our NICU, and it worked well. But yeah, you definitely want to use some type of lubrication between the two so your hands slide.
Yeah. Okay, great. And then do you nest in an open crib or only in a giraffe bed? Preparing family going home without boundaries gets tricky.
Agree. We did nest in cribettes. Again, when in our NICU, we had certain policies depending on medical, what was going on with them medically and their age, or if they're getting close to going home. We always wanted to really practice those safe sleep practices prior to going home. So the baby one was used to it. And then number two, the family, we were, showing them best practice.
Yeah. Okay, great. Thank you. And Katie, I see that you've got 2 other groups that you can suggest that teach NICU massage. And I think you put those in the chat potentially. And if not, if you want to go and put those there, that'd be great. So everybody can see them. Thank you for that suggestion. Okay, so that seems like all the questions from the group. Kathy Randall or Kathy Bush, do you want to close us out?
Oh, just great job. Thank you.
Fantastic.
It's always such a great discussion about back to sleep. It's such a I think it's one of those things where we try to balance the needs of the baby versus these policies. And I think you guys had a really great discussion about that. And I just like to remind people that back to sleep is for healthy babies. And, so I think we have to kind of weigh that difference between whether or not the baby still has some intensive care needs. That's why they're in the NICU, and whether or not it's appropriate to apply those policies to those babies at that time. And definitely we want to support transition time, but I think it's also, we get a little myopic sometimes about the policy, and it's really about communication. Like, what's the therapeutic need of the baby? And like you were saying, even for the prone time, it's really about prone for play. It's really therapeutic time that's part of their, developmental pathway. So I think sometimes it's just better communication, and communication between nights and day shift. I think, especially if you're in a unit that allows positioning aids in the cribettes, and then, at night shift, everybody puts them back in, and day shift, they pull them all out, and, the baby gets confused and the parents get confused. So having really clear documentation and where we are in the plan, I think is always really helpful. At least the places I've worked, we've always tried to work towards better communication about that. I think is one of those things, but no, it was excellent. Thank you. Really nice. I loved all the videos.
Oh, thank you. Proud of all those kids.
Yeah. So Kathy Bush, you can kind of wrap us up.
Just there's been some good information in the chat area. There is a handout. Again, it will be included in your follow-up email, but it's also available as a link in the chat about 6 chats up, and some other information that people shared. So this webinar was brought to you by DandleLION Medical, and we are thrilled to have experts like Chelli as part of our webinar series. In order to receive your free CE, you will need to fill out the webinar evaluation. When I'm done talking, you'll automatically be redirected to the evaluation that must be completed in order to receive your CEU. If you're watching the recording, please go back to the email you received with a link to the recording and click on the link to the evaluation form. You will receive an email with a PDF of your CE certificate within about 24 hours after you do the evaluation. And be sure to check your spam if you don't get it within that 24-hour period. If you are viewing as a group, you must each log on to the evaluation form in order to get your individual CE. There's no group CE certificates. And just another note from DandleLION, in the last month or last couple of months, there's been a significant shift in the positioning aid market. And DandleLION Medical has recently released 3 new products: a cloth and a disposable Snuggly-Roo, and a small beanbag positioner called the PolyPal. And we have many tools to help make switching to DandleLION products really easy, including in-service videos, pictorial instructions, and other resources to help with staff education. And Alex and her clinical team are also available to meet with your team via Zoom to discuss your positioning needs or to help you with education or in-servicing. And we're really looking forward to working with you. This is what we love to do and what we do best. One-on-one education and support for you and your team from Alex and her team. So just a final reminder to visit our website for the links to the recordings of our previous 3 years of webinars. They're all still active and available for continuing education credits. So thanks again, all of you. Thanks so much, Chelli, for the great presentation, especially those amazing videos. And you will be redirected as soon as we click off over to the evaluation link. So see you at the next Dandy webinar.